uh, sepsis kills. Once I saw the flyer regarding this topic, bit of weird and scary, isn't it? But I thought Madam might have thought the best topic, sepsis kills. The objectives of the presentation are burden of sepsis, sepsis and its latest definitions, when to suspect sepsis and stabilization of patient, escalation to ICU, management of sepsis and post-sepsis syndrome. Burden of sepsis as given by the Global Sepsis Alliance. By this time you might have familiar with this photo very much because we are at the end of last few hours of the sepsis month. So throughout the month you had read, you had listened, you had read sepsis, But just to recap, I just want to say 50 million cases per year are reported with sepsis. And out of that 50 million people, 11 die per year. And 1 in 5 deaths worldwide is associated with sepsis. And sepsis is the #1 cause of deaths in hospitals, cause for hospital readmissions, and healthcare cost. 40% of cases are children under 5 years, and 80% cases report in the community. I know you all treated nicely 2 hours patients with sepsis, recover them and send home. But I'm not sure whether you see them after sending home. But 50% of survivors suffer from post-sepsis syndrome. So it is the patient, death, and survivors. Everybody suffer if they get sepsis. So why a sepsis day? Global Sepsis Alliance identified the problem and declared 13th of September as the World Sepsis Day to improve awareness on life-threatening condition sepsis. Fall month sepsis, September sepsis month. Why? Because they had found that sepsis had become the #1 preventable cause of death due to lack of knowledge about sepsis. And hope you all know that death and disability from sepsis is preventable by early recognition and effective treatment. For that, we have to aware on sepsis. Definitions. This is the simplest thing I can show you. Somebody gets infections, deteriorate to infection which causes mortality more than 20%, and if they further deteriorate, they go for septic shock which causes mortality of more than 40%. What is an infection? We all talk infection. What is it? It is the invasion of body tissues by disease-causing agents. The microorganisms enter the circulation and they multiply in the body and releases infectious agents and the toxins. But our body has a physiological response to that to protect us from infection. That is host response. With that interaction, organisms die and infection is cured. But if we don't identify an infection at the correct time and our immune system or our host response is dysregulated, infection can deteriorate to life-threatening organ dysfunction, sepsis. Further deteriorates to septic shock, that is, in the body therefore develops circulatory, cellular, and metabolic abnormalities, which makes the patient more increased mortality rate. So we know infection, sepsis, and septic shock. How these changes happen, or the pathophysiology of sepsis. Once the microorganisms enter the circulated body, They release different toxins to the host tissues. The reaction occurs and body releases pro and anti-inflammatory mediators such as oxidating agents, cytotoxins, and bacteria endotoxins or exotoxins. These inflammatory mediators mainly affect endothelium, microvasculature of the body, and the coagulation system. So once infection is there, microorganisms releases toxins and body has its own response, which releases inflammatory mediators. When they act on the endothelium has the glycocalyceal system in the wall. The glycocalyceal system gets damaged with the inflammatory mediators and causes impaired permeability of the vascular endothelium. This causes intravascular compartment leaking towards the extravascular compartment. With the leaking, intravascular volume reduces, which causes hypovolemia and blood pressure drop. Not only that, extravasation or the leaking of fluid, intravascular fluid, causes tissue edema. When it can consider microvascular stir, because of the inflammatory mediators, nitric oxide synthase pathway get activated, lots of nitric oxide is released that act on vascular endothelial smooth muscle cells and causes relaxation, which results in vasodilatation. That causes systemic vascular resistance drop and further blood pressure drop. In the coagulation system, both thrombin and antithrombin pathways get activated and microthrombi formation. All these affect all the vital organs of the body, which makes multi-organ failure. And depending on the host condition, this can get worsened, such as comorbidity, genetic factors, or the immunity. The common sites of or the sources of infection they had found, respiratory infections are commonest cause for sepsis, and it is about 43%. And others could be central nervous infections such as meningitis or encephalitis, soft tissues and skin infections, urinary tract infection, abdominal infections. With that in mind, we'll go for what we have to do when we get the patient. Please keep the details in your mind or in a paper. Hope you have a pen and a paper with you. This is the emergency treatment unit at 12 p.m. Mr. K, 45 years old gentleman, admitted to the ETU with a history of fever, right lower limb swelling, and redness for 3 days duration. In the background of diabetes mellitus for 5 years with poor compliance, and however he had not taken his regular hypoglycemic medication for past 3 days. Initial assessment is as following. Airway is patent, respiratory rate is 25, and examination is normal. Other examination, saturation is 92% on room air. Cardiovascular system, peripheries are cold with capillary refilling time of 4 seconds. Respiratory rate is 110 and blood pressure is 80/30 with MAP of 47. Disability, Glasgow Coma scale is 14, CPS 350. On examination, their exposure, his right lower leg has cellulitis and temperature is 38. ETU doctor quickly did the venous blood gas analysis. This is the venous blood gas report. pH is 7.2 with PaO2 of 82, PaCO2 of 25, bicarb 16, lactate 4, electrolytes within normal range. What do you think? I know your mics are open, so I would go ahead. If anybody want to answer, you can unmute your mic and answer. So, with the history and your examination findings and venous blood gas analysis, just ask yourself, could it be sepsis? Do you think? Yeah. What is sepsis? It is suspected or documented infection with organ dysfunction. How we can assess? There are lots of screening tools. Why one is not enough? No, because we have to spot it at correct time. It is a time-consuming diagnosis. We have to diagnose at the time zero. That's why there are many tools. If one fails, you have to apply other one or combination of tools you can apply. First, we talk on quick SOFA scale. You all know this is a bedside. Quick sequential organ failure assessment. You might have heard this throughout the month. I'm just saying. HAT, hypotension, systolic blood pressure less than 100, altered conscious level, that is this is less than 15, and tachypnea, respiratory rate more than 22. If somebody is having 2 or more points, this is highly suspicious of sepsis. Then NEWS score, modified early warning score, or you are more familiar with NEWS, National Early Warning Score. You might have got this observation chart in your chat box by now, so you can have a look because this is not much clear in my screen. But just to explain you, this is the UK National Early Warning Score. They talk on few vital parameters and had given marks. They look for respiratory rate, oxygen saturation, supplementary oxygen is given or not, temperature, systolic blood pressure, heart rate, and level of consciousness. If all the parameters are within normal range, we give a mark of 0. Depending on the severity of deterioration, the score goes up. This is for National Early Warning Score, the modified early warning score. Then we get systemic inflammatory response syndrome or the SIRS criteria. It says temperature more than 38 or 36 Celsius degrees, heart rate more than 90, respiratory rate more than 25 or due to hyperventilation, PaCO2 less than 32. If we do the full blood count, white cell count would be more than 12,000 or less than 4,000. SOFA score. We initially discussed quick SOFA score. It was developed from SOFA score and it again gets some vital organ function. Respiratory system with oxygenation index, that is PF ratio you simply say, coagulation with platelet count, liver with bilirubin, severe with mean arterial pressure or whether the patient is supplementary blood pressures, central nervous with Black-Scholes scale, and renal with creatinine or urine output. If all are within normal range, the patient would get a number of 0, but depending on the deterioration, the score gets increased. So, how we are going to give the numbers for your patient? If we apply for Mr. K, the Q SOFA score, he gets 3. He's having hypotension, low GCS, and tachypneic. SIRS also, he has 3. At the moment, we don't have vital count. Respiratory rate 25, temperature 38, heart rate 90. So, can we come to the diagnosis of sepsis? Yes, he has evidence of infection, that is, he has cellulitis of his leg, plus 2 of the screening tools positive. What you are going to do with your patient? Sepsis is a medical emergency. We don't have time to think. From time zero, again I'm saying time sensitive diagnosis. From time zero, we have to act. So the Surviving Sepsis Campaign guideline says our one bundle: measure lactate level, obtain cultures, administer broad spectrum antibiotics, rapid administration of fluids, and vasopressors if we can't achieve mean arterial pressure of 65 with fluid resuscitation. And this also you all know, sepsis 6, very simple. That says give 3, take out, or simply we say 3 in, 3 out. Within initial management, we have to give antibiotics, fluids, and oxygen, and take 3 out, lactate, urine output, blood cultures. So we'll go first one of the
Dr. Nandika, sorry.
Sorry.
Yeah.
Yeah. There's a noise coming from behind your voice. I think you have
yeah, my phone, so I'll switch it off. Yeah,
extremely sorry.
that's okay. Hope it is okay now. Dr.
Yes,
Chandra?
yes.
Yeah, okay, sorry. So first one is measure lactate levels. The VBG level already done the ETU. It says 4. If you don't have facilities to measure lactate level, they say it is okay because they had done researches in lower middle income countries, and they had found that not all the institutions don't have blood gas measurements. But still, what we measure from the won't lactate level, it gives the indication of organ perfusion. For that, we can assess patients' capillary refilling time or peripheries, whether warm or cold, or urine output assessment. So even though we don't have lactate measuring facilities, we can assess perfusion status clinically. Second is take appropriate cultures. We have to take cultures before antibiotics because after starting antibiotics, microorganisms get destroyed and we may not able to identify what is the organism later. So we have to take appropriate cultures from the probable septic site and blood cultures. We have to take 2 blood cultures from 2 different sites. But if you don't have facilities to do cultures within 1 hour of diagnosing sepsis, maybe no culture bottles available, or then without irrespective of culture taking, start on antibiotic treatment within 45 minutes. For our patient, Mr. K, we took 2 blood samples and tissue cultures we have to take as he said cellulitis, but it is intact, its skin, only redness and swelling. There's nothing to be taken. And I have to say, if you have evidence of sepsis but no site of infection, we have to do septic screen, that is urine, sputum. If indwelling devices are present from that are such as central venous catheters, intercostal tubes or abdominal drains, take samples from those devices. Number 3 is administration of broad spectrum antibiotics. We discussed some in the cultures. Within 1 hour, we have to use, and in this graph it says the time of initiating antibiotics and survival rate of our patient. If we start antibiotic within the 0 hour, the recovery of our person is 80%. But every hour in delay starting antibiotics, the survival rate rapidly drops. And empirical antibiotics should be started according to the site also. And if you think there are multiple organisms such as, and you don't know, gram-negative, gram-positive, cocci, bacilli, you can combine antibiotics accordingly. And We don't empirically start while antivirals or antifungals, but if you suspect it is a fungal or viral infection, accordingly you can start. So, are we starting antibiotics our own? Then, sepsis, how we decide. Sepsis is definite or probable. Irrespective of presence of shock or not, we initiate antibiotics immediately. But if sepsis is possible, only we think. But if the patient is having shock, we initiate antibiotics. But if there's no state of shock, we can exclude other causes and give antibiotics. But keep in mind, if you cannot come to a conclusion, the symptoms and signs are due to any other cause other than sepsis, you start antibiotics within 3 hours. How we are going to start? According to empirical and prophylactic use of antibiotic guidelines, this is given by the ministry and prepared by the College of Microbiologists. You can refer the book if you don't know what to start. So, this patient is having septal cellulitis, that is sepsis. It says we can give Coamoxiclav, Fluclox, benzyl penicillin, or clindamycin, or as combination. You can refer this book when you want any antimicrobial to be started. So for Mr. K, we started on IV Coamoxiclav 1.2 gram 8 hourly as he has no known allergies. Then fourth is administration of fluids. You can start on balanced crystalloid, that is Hartmann or available balanced crystalloid, so saline. And at least 30 ml per kg we have to initiate within first 3 hours. So we start done the up to number 4 of our one bundle. We started fluids, oxygen therapy initiated, other things being done. When we reassess the patient, airways patent, respiratory rate had come down to 22, other respiratory examination normal, and started on oxygen via non-rebreathing face mask with get 97% of saturation. Circulation, still peripheries are called. CRFT is 4 seconds, heart rate 95, blood pressure slight improvement, blood still low, 85/40 with MAP of 55. Still GCS 14 with temperature of 37. Now, what is your diagnosis? You had done the fluid resuscitation, still you couldn't achieve the mean arterial pressure. Our patient is in septic shock. What is septic shock? Despite adequate volume resuscitation, persisting hypotension, requiring vasopressors to keep mean arterial pressure more than 65 and lactate more than 2. What we are going to do now? We have to start on vasopressors. The 5th number of our one bundle. Sorry. So the recommended first vasopressor of choice is noradrenaline. You can start with 0.05 to 0.5 microgram per kg per hour. As this is an emergency, we don't have to wait till central venous catheter insertion. We can start noradrenaline via peripheral access. If you don't have noradrenaline, again, they say in resource poor situation, you can start on adrenaline. So, our one bundle completed or initiated. Anything else we have to do at TTU? What comes to your mind? Anybody want to start? Yeah. We have to consider on source control, inform the surgical team about cellulitis. Surgeon came and see the patient and he said no need of surgical intervention at the moment and patient is for medical management with antibiotics. As the patient's blood sugar is 350, soluble insulin being started. Now, the suppressors also started. The changes are breathing, respiratory rate came down to 20 and de-escalated supplementary oxygen. Now he is on 50% oxygen via face mask or the Venturi mask with saturation of 96. Periphery is being improved to 1. Capillary refilling time 3 seconds. Heart rate with high still 112. Blood pressure 100/50 with MAP of 66. He is on noradrenaline 0.1. TCS being improved to 15. CBS coming down to 290. He is having cellulitis. Now, what is the mu score? We can give airway and breathing too because he is on supplementary oxygen. Please see your news chart in your hand in the chat box. Circulation we can give because he is having systolic pressure of 100 but high heart rate gives 2. DNE we can give 0. His 5 of mu score and plan for hourly monitoring in the high dependency unit. We transferred the patient to the medical ward. At 3 p.m., BP seen the patient, physicians or the patient. He advised to monitor MUS hourly, continue fluid resuscitation, monitor urine output and maintain more than 0.5 ml per kg per hour, trace the investigation sent from the emergency unit, microbiology opinion and glycemic control. So they are maintaining MUS. So they are continuing fluid resuscitation, but how we evaluate whether resuscitation is good? We have to assess fluid status of the patient. How? Adequacy of fluid management we can assess with dynamic parameters. That is stroke volume variation or pulse pressure variation if we have an arterial catheter inside. For cardiac output monitoring with transthoracic echo. Dynamic parameters are better than static, but if you don't have facilities for that, that's fine. We can assess clinically. How? How are the peripheries, capillary refilling time, and urine output? So we can assess adequacy of fluid management. Then, how we know whether fluid patient is responding to fluid? We can do passive leg raising test or facilities available. IVC, inferior vena cava cholesterolity, we can check with ultrasound scanning. But be careful, when we give fluid, the patient can get overloaded also. Keep an eye on fluid overload by examination of lungs for bibasal crevitations. So, once you are giving fluid, but you think now the recommended amount had been exceeded or too much, you can consider on albumin. But please don't give starch solutions because it has a high risk of renal damage. Especially in septic patients, they are high risk of getting renal damage. When considering our patient whom we are talking, he is with diabetes also, who is at risk of getting diabetic nephropathy. So, not starches, but albumin you can consider. Then we got the reports which we had sent from the emergency unit. White cell count of 18,000, hemoglobin of 8.5, platelet count of 40,000. CRP is 180, creatinine 2.5, electrolytes normal, elevated liver functions with enzymes, and INR is 1.7. ECG shows sinus tachycardia, but there's no ischemic changes. After 3 hours in the ward, while monitoring the patient's new score, airways patent, respiratory rate is 20 per minute, saturation 97%. Now they had de-escalated some more, oxygen via simple face mask. Pulse rate still high 112, blood pressure 140 101/40, and they had to increase noradrenaline to 0.2 because MAP being 61. Urine output marginal 0.4 ml per kg per hour. We got a mu score 4. So, according to the Muse chart, we can monitor the patient now with 4 hourly, but still in the high dependency unit with careful observation. Now, they had got the reports which they had sent from the ward once he was admitted. White cell count 17,000, hemoglobin 8, and platelet 30,000. Creatinine further risen to 3, potassium is rising to 5.5, liver enzymes further elevated with bilirubin of 1.3, it is upper normal. It is elevated again. INR is 2, which indicates patient is not doing well. Overnight, nothing was informed, but suddenly at 6 a.m. BP get the call. Airway still patent, breathing deteriorating. Respiratory rate is 28, saturation 92, and they had escalated to NRBM again and found to have crepitations on lung bases. Pulse rate 110 with 90 of systolic blood pressure and MAP of 57 with 0.2 of noradrenaline. Capillary refilling is still 3 seconds and bit of deterioration of nervous system or the disability. He is now not alert but responds to verbal. CBS is dropping to 200, temperature high, and found to have further deterioration of renal with urine output of 0.2. What do you think about the mu score now? Any good? When given, it had been risen to 11 from 4 yesterday 6 p.m. So they contacted the ICU for an ICU bed and transferred the patient to ICU. At 7 a.m., patient was admitted to the ICU. Airway still patent, but respiratory rate is 35 by basal crepitation and saturation is 90 with oxygen via non-rebreathing mask. In the ICU, they started on non-invasive ventilation with CPAP with pressure support of 8 and PEEP 6. Pulse rate is 100 with blood pressure of 90/40 with mean arterial pressure of 56, which is not adequate, and capillary refilling time of 3 seconds. They increased noradrenaline to 0.4. TCS drop-in now, it is 12 with CBS of 250, which started on soluble insulin according to the algorithm. He is now having mottled skin with temperature of 38 and oliguric. ABG on admission to ICU, pH 7.2 with PaO2 of 140. This is with CPAP just after initiation. PCO2 28, bicarb 15, and lactate is 5. Sequential organ failure assessment score was chart and it says 15. What we are going to do now? We manage the patient according to the ABC. A and B, now NIV was started with CPAP, but if you have facilities, you can give high flow nasal oxygen also. But if your patient is responding, you can continue with that. But if no response or no improvement or further deterioration, you have to escalate respiratory support to invasive ventilation. That is intubation and mechanical ventilation. We have to apply lung protective ventilation and other support with chest physiotherapy and ventilator care bundle. When we ventilate the patient, we have to maintain adequate sedation and analgesia. Circulation. So already on noradrenaline, but if you can't maintain mean arterial pressure more than 65, or he shows signs of peripheral coldness, vasoconstriction, cyanosis, you can add second vasopressor, vasopressin. Further, if you have to escalate, adrenaline, dobutamine is if cardiac contractility is not good, and dopamine. When the vasopressor supports go up, it's good to insert a central venous catheter plus add on invasive blood pressure monitoring. Now, we had to increase noradrenaline to our patient for 0.5 micrograms per kg per hour and started on vasopressin also. What we have to do when the vasopressor requirement goes up, and it is been 4 hours. The recommendation is start on steroids. When to start? Noradrenaline or adrenaline dose is more than 0.25 microgram per kg per minute for more than 2 hours. We have to start on hydrocortisone at a dose of 200 milligram over for 24 hours. This could be given as a continuous infusion or regular doses 550 milligrams 6 hours. Just if I forget to tell again, I just mentioned here, when you start on hydrocortisone with escalating vasopressor support, when you come down with the blood pressure support, you can tail off steroid dose. Then antibiotics, they had started already on antibiotics, but we have to make sure we trace the culture reports and de-escalate the empirical antibiotic treatment for narrow down. And we can decide it on clinical response also. For our patient, still the culture and ABST report not available as it was sent just the day before. It takes about 24 hours to take first and more than that for ABST. So following day at 7 a.m. now, the day 2 in the ICU. He is on mechanical ventilation with bibasal crepitations, pulse rate 115, with blood pressure of 110 and MAP 70 with noradrenaline and vasopressin, IV fluids on maintenance volume. He is well sedated with CBS of 203 and they are adjusting the infusion of insulin. Ultrasound scan abdomen says IVC is 2 centimeters and bedside echo reveals right ventricular dilatation with flattened septum. Why we look for that? He has no urine out for past 6 hours with creatinine of 3. What is your plan? ABG shows pH of 7.1, bicarb of 12 and lactate of 6 with potassium 5.8. Something comes to your mind, I know, whether we go for renal support. Now we had corrected the volume status and blood pressure almost established, but his renal is deteriorating. Do we have to go for hemodialysis? The recommendation is dialysis to be started with sepsis and AKI if the patient is having other absolute indications for dialysis. Those are uremic complications, refractory acidemia, and refractory fluid overload. Both acidemia and refractory fluid overload our patient is having. So what are options for renal replacement therapy? So we have to initiate renal replacement therapy for this patient. We do have two options here, intermittent hemodialysis or continuous renal replacement therapy. As this patient is unstable, he may not be possible to mobilize to the dialysis unit for intermittent hemodialysis. Even though we brought him to the dialysis unit, it would be difficult to take such volume, rapid changes the patient won't be tolerate. So continuous renal replacement therapy would be offered. But I had to say they had found there no outcome different whether the patient undergone intermittent hemodialysis or CRRT. But you can decide which mode, but he needs renal replacement therapy. Then at 8 a.m., surgeon came to see the patient. Cellulitis getting worsening, CRP further risen to 250, white cell count to 23,000. Ultrasound scan of the leg being done, it has been found fluid collection with the fascia suggestive of abscess formation. So the surgeon plans for source control. He says damage control, emergency incision and drainage could be done to remove necrotic tissue and debridement. So we plan for IND of the field. At the same time, we got the reports, these reports. His hemoglobin is 8, platelet count is 20,000, with INR of 2.2 and prothrombin time 30 seconds. Even though this coagulation is deteriorated according to numbers, he has no bleeding manifestations at the moment. But we have to do the vascular catheter insertion for dialysis plus IND for the wound. What you are going to do now? Are you going to directly proceed or you want to do something? Regarding blood and blood products transfusion, the restrictive or liberal transfusion therapy they had discussed in Surviving Sepsis Campaign guidelines. They recommend to transfuse blood if hemoglobin is less than 7 grams per deciliter. But again, the numbers, we have to correlate the scenario with our patient and it should be individualized. If your patient is a cardiac patient, better to target 9 grams per deciliter. But other factors like active bleeding also matters. As our patient is having 8 grams of deciliter, we did not transfuse. When to give FFP? The patient's INR is 2.2 with prothrombin time of 30. Again, patients who not having bleeding but prolonged coagulation, we should not transfuse unless they go for invasive procedure. Patients with bleeding, with prolonged PT and APTT, we can give FFP though he is going for a procedure or not. Platelets, again with bleeding or high risk of bleeding such as going for surgery, post-operative or invasive procedure, and count is less than 50,000, we consider for transfusion. But though the count is low, non-bleeding, we are not transfusing platelets unless it is less than 10,000. For Mr. K, we transfuse an adult pack of platelets and fresh frozen plasma 15 ml per kg for and then vascular catheter inserted and CRRT initiated and IND of the wound being done. Then the glycemic control comes. Now the patient's CBS is 350. What is the best management? We have several options for glycemic control. Whether to give IV insulin or subcut, oral. The recommendation is if your patient's blood sugar level is more than 180 milligram per deciliter, we have to initiate insulin therapy and with target of 144 over and between 144 and 180 milligrams per deciliter. Other supportive care in the ICU or the sepsis patient, We have to give deep vein thrombus prophylaxis. This is a critically ill patient, non-bleeding. We do have two options, pharmacological and mechanical. We do have pharmacological prophylaxis with low molecular weight heparin or unfractionated heparin. Low molecular weight heparin is preferred over unfractionated heparin, but whatever you give, always consider contraindications and exclude those things and initiate. Mechanical prophylaxis could be done with intermittent pneumatic compressions or graduated compression stockings. Both methods you can initiate, but if there are contraindications for pharmacological, definitely you have to go for mechanical and make sure your patient is well hydrated. Again, sepsis is highly stressful condition which can cause GI bleeding. Patients who are having risk factors for GI bleeding, we go for stress ulcer prophylaxis. We can start on proton pump inhibitors or histamine releasing drugs. Nutritional support with to be started, but not if the mean arterial pressure is 65. Once MAP is achieved, you can start on nutritional treatment and gradually increase once hemodynamics are stable. We managed the patient nicely and he was discharged from to the ICU to the ward and ward to the home. And he was reviewed in the clinic and maintained the ICU diary also what they had done each day. After reviewing the clinic, he comes and tell you he's having these problems, these disturbances, weakness, tiredness, and he had mentioned these days in the ICU diary. Now, what is your diagnosis? This patient is having post-sepsis syndrome. This is both psychological and physical disabilities our patients get once they had treated for sepsis for long term with lots of invasive procedures. What is managed?
කවුද නැතුවගේද? තව
We
බෙහෙත්
can manage him with physiotherapy and occupational therapy, advise on proper nutrition and refer him for rehabilitation. And we have to keep in mind post-sepsis syndrome to be considered while the patient is on treatment for sepsis. Early physiotherapy and nutrition, educate patient and family, and early post-discharge review. Family knows about sepsis now and they ask why their relative got sepsis. What are the risk factors? Risk factors for sepsis are people with chronic diseases such as lung, liver or heart diseases, people with no spleen and who are immunely compromised. So our patient is long-term diabetic, he could have less immunity, and children under 5 years of age and elderly. Further questions from your patient's relatives to you. Could it be prevented? Yes. We have to get vaccination at correct time, use clean water, proper hand hygiene, and we have to very much careful when they are in the hospital for hospital-acquired infections. That is, they may not be admitted with infection or sepsis. They are for management for any other conditions such as myocardial infarction thing. Even though once they are in hospital, they are more prone to hospital-acquired pneumonia. And safe childbirth and awareness is very important to prevent sepsis. So we manage the patient, educate, the family is happy.